awfully bright in here. Hi, everybody. Tonight's lecture is on infectious and inflammatory disorders of the lower respiratory tract. The lower respiratory tract is protected against infection and inflammation by a variety of defenses. But when one of these defenses break down, infection and inflammation can cause serious problems. First of all, the lower respiratory tract is protected by the upper respiratory tract. Microorganisms have to get past here first. So that's the cilia, the mucus, and the cough reflex. Should an organism make it past these defenses of the upper respiratory tract, mucus in the lower respiratory tract will trap them. The cilia and cough reflex push the mucus-trapped organisms up and out of the body. Even after microorganisms make it past these barriers, immune factors of the lower respiratory system will probably destroy them. These barriers are broken down by such things as chronic lung disease, terminal illness, and aging. Medically compromised individuals also have a higher incidence of lower respiratory tract infections. Lower respiratory tract infections are often opportunistic. By that I mean they see the opportunity to take advantage of a person in a rundown state of health. By a rundown state of health, I mean patients undergoing chemo, HIV-positive patients, and anyone in a poor state of health due to other medical reasons. It may be that you're recovering from the flu. Because you're in a rundown state, you have a good chance of developing pneumonia. We are specifically going to talk about acute inflammatory and infectious diseases of the lower respiratory tract tonight, however. In other words, disorders with a sudden onset and dramatic signs and symptoms that run a short course. If they are not resolved, they may become chronic. We will look at acute bronchitis, lung abscess, acute empyema, pneumonia, and tuberculosis. Let's first begin with a brief overview of each of the conditions I just mentioned, followed by a discussion of interdisciplinary care later in the lecture. With all lower respiratory infections, there is a cough and fever. The character of these two symptoms may vary depending on the causative organism, but there is always a cough and a fever. First of all, acute bronchitis. Acute bronchitis is the sudden inflammation of the mucous membrane linings of the bronchi. Usually acute bronchitis follows a URI. The infection extends into the bronchi and inflammation occurs, which leads to edema and increased mucus production. A cough is caused by the increased mucus production, and it begins as a non-productive cough but becomes productive as the infection progresses. Coughing is the primary symptom of acute bronchitis, and it can occur in uncontrollable bursts or paroxysms and become worse with cold, dry, dusty air. The cough is usually worse at night. Patients may complain of a substernal chest pain, fever, and malaise. People with impaired defenses and smokers are at a higher risk for contracting acute bronchitis. Acute bronchitis can be caused by viruses, bacteria, toxic gases, or chemicals. In next week's lecture, we're going to talk about obstructive pulmonary diseases, which will be chronic bronchitis. But don't get these two things mixed up. Acute bronchitis is infectious. Chronic bronchitis is not. The second topic is pneumonia. Pneumonia literally means inflammation and infection of the bronchioles and alveoli. Many things can cause pneumonia, and it can be infectious or non-infectious. Infectious pneumonia is caused by viruses, bacteria, fungi, and all other microorganisms. There are over 50 organisms that cause pneumonia. Non-infectious pneumonia can be caused by aspiration or inhalation of toxic gases or chemicals. Pneumonia is the 9th leading cause of death in this country, especially with the older adult and people suffering from debilitating diseases. For example, pneumonia is one of the leading causes of death in people with AIDS and chemotherapy patients. Classifications of pneumonia. There are several different ways that pneumonia can be classified. First, it can be classified as community-acquired pneumonia, which is CAP, or healthcare-acquired pneumonia, HAP. Pneumonia can also be categorized as infectious or non-infectious. Pneumonia is subcategorized as typical or atypical. So typical pneumonia is caused from a bacterial infection of the alveoli. Atypical pneumonia is caused by other organisms, not bacteria. So remember, typical pneumonia is bacterial. Atypical pneumonia is any other organism that is not a bacteria. So with all those classifications in mind, pneumonia can also be classified by the place it is acquired in the causative event. Pneumonia is also classified by its location. It can be confined to one lobe of the lung, and then we call it lobar pneumonia, or it may be diffuse and patchy throughout the lung, and that's bronchopneumonia. So, for example, if I'm writing down that someone has community-acquired pneumonia that's bacterial, that's in the left lobe of their lung only, I would classify it as CAP, typical pneumococcal, which would be the bacteria, and lobar. To recap, pneumonia is classified by community-acquired or hospital-acquired. Is it infectious or non-infectious? Is it typical, meaning it's bacterial, or is it atypical, caused by other microorganisms? And its location, is it lobar or broncho? There's many risk factors associated with developing pneumonia. First is cigarette smoking. Second are medications, alcohol, and illegal substances that impair your consciousness. Impaired immunity, such as AIDS, cancer, chemotherapy patients. People suffering from chronic diseases are more prone to developing pneumonia. So by that I mean people with COPD or chronic obstructive pulmonary disorder, diabetes, congestive heart failure, liver disease, or kidney disease. The pathology of infectious pneumonia. Usually the microbes that cause pneumonia colonize in the nasal pharynx or oral pharynx, so in your throat. The microbes enter the lung because secretions from the throat or pharynx are aspirated through the trachea. Sneezing, coughing, and even talking may cause microorganisms to be inhaled. Inhaled pathogens can also be inhaled via contaminated water and air conditioning units, and you'll learn more about that. It's called Legionnaire's disease. When organisms enter the lung, it leads to an inflammatory response because the body wants to get rid of them. The alveoli become edematous and fill with fluid. Blood cells and bacteria accumulate in the alveoli and bronchioles. The blood cells and bacteria consolidate or form into a hardened area, and due to gravity sink into the lower lungs of the it's hard to say. And because of gravity, sink into the lower lobes of the lungs. Say that 10 times fast. A breeding ground for bacteria is established by the edema, fluid, and debris, and eventually the infection spreads to other parts of the lung. As the infection resolves, macrophages digest and remove the fluid, bacteria, and damaged cells. Typical pneumonia, pneumococcal pneumonia. Typical pneumonia is caused by bacteria. It has an abrupt onset with fever and chills, a productive cough, with rust-colored purulent sputum. Breath sounds are diminished. When someone has pneumonia, you don't get good breath sounds, you get diminished breath sounds. But you might hear fine crackles over the affected area. The chest pain is localized and may be described as aching or sharp. The most common complication is pleuritis or pleurisy, which means painful inflammation of the pleura, you know, that those 2 layers that line the lungs. Other complications are caused by damage to lung tissue, leading to necrosis, abscess, and empyema. We'll talk about that later, but empyema is a collection of pus in the pleural cavity, that pleural space between the 2 layers. Bacterial pneumonia is generally more severe than atypical pneumonia. Atypical pneumonia generally runs a milder course than bacterial pneumonia with symptoms that mimic the flu. It's often referred to as walking pneumonia. I know you've heard that term. Young adults, like college students, military recruits, probably have the highest incidence of atypical pneumonia. Depending on the organism, it can be highly contagious. Signs and symptoms are fever, headache, muscle aches, malaise, and a dry, hacking, non-productive cough. Atypical pneumonia is self-limiting, but the cough may linger for up to 6 weeks and tends to be worse at night. So now let's compare and contrast typical and atypical pneumonia. Typical pneumonia is bacterial, atypical is non-bacterial. Typical pneumonia has an abrupt onset. Atypical pneumonia has a more gradual onset and a milder course. Typical pneumonia has fever, shaking, and chills, where you're just going to have the fever and it won't be as high with atypical. Typical pneumonia has a cough, a productive cough, with rust-colored purulent sputum. Atypical pneumonia has a cough, but it's dry, hacking, and non-productive. With typical pneumonia, you have tachypnea and dyspnea. With atypical, you have flu-like symptoms. In fact, atypical pneumonia mimics the flu. With typical pneumonia, people complain of pleuritic chest pain. The complaints with atypical pneumonia are headache, malaise, muscle and joint pain, and it's often referred to as walking pneumonia. With typical pneumonia, people have diminished breath sounds and fine crackles because all that mucus and fluid fills up in the lungs and you can't hear the breath sounds. Complications of typical pneumonia are pleurisy, which is that painful inflammation of the pleura, lung damage leading to necrosis, abscess, and empyema. Atypical pneumonia usually runs its course. So now I'm going to go over a few of the actual causes of pneumonia, the causative agent. First, acute bacterial pneumonia. Pneumococcal pneumonia is caused by the Streptococcus bacteria, and this is the most common type of bacterial pneumonia. There's also pneumocystis pneumonia. This type of pneumonia is caused by a common parasite. This is the leading type of pneumonia contracted by people with AIDS. People with healthy immune systems are rarely affected by pneumocystis pneumonia. It has an abrupt onset. The alveoli become edematous and fill. This is the odd thing about it. The alveoli fill with a foamy, protein-rich fluid, which is going to cause a dry cough and respiratory distress. Then there's Legionnaire's disease. Legionnaire's disease is caused by a bacteria. It occurs in sporadic outbreaks due to a bacteria that grows in warm, standing water. Outbreaks occur in hospitals and businesses where it is spread through the air conditioning vents. Legionnaire's disease was named and discovered in 1976 when an outbreak occurred at the American Legion Convention in Philadelphia. People with chronic diseases, compromised immune systems, and the elderly are at most at risk for Legionnaires. The signs and symptoms include a dry cough and severe flu-like symptoms. And then lastly, viral pneumonia. The onset is usually gradual, and the patient has a dry cough and flu-like symptoms until the pneumonia runs its course. The next thing I want to talk about is H1N1. H1N1 is a URI, which is a form of the swine flu. It is caused by a virus. Severe pneumonia can result as a complication of H1N1. It is a rare complication that occurs primarily in young children, young adults, and pregnant women for some reason. This complication rapidly leads to acute respiratory distress syndrome. The symptoms of H1N1 are usually typical of flu-like symptoms, as we discussed. However, dyspnea, difficulty breathing, cyanosis, or a significant drop in O2 saturation should be immediately reported, as they may be the preliminary symptoms of severe pneumonia and lead to severe respiratory distress syndrome and respiratory failure. And then I'm not going to review the signs and symptoms of COVID-19. It's been in the news, and we report it and do screenings all the time. But like H1N1, COVID-19 can lead to some various serious complications where people wind up on ventilators, and it can be it can be life-threatening, while other people have flu-like type symptoms. It runs its course and they get better. There won't be any questions on COVID. The next thing I'm going to talk about is a lung abscess and empyema. A lung abscess is a potential complication of pneumonia, and it could be of other respiratory infections. It's not exclusive of pneumonia. A lung abscess leads to local lung destruction or necrosis of that part of the lung and pus formation in the lung tissues. Aspiration pneumonia is the most common cause of a lung abscess. Empyema, I like to say that word, it sounds like Empanema, you know, the girl from Empanema. Well, you probably don't. That's an old song. But that's what it reminds me of. Empyema, like a lung abscess, is a potential complication of a lower respiratory tract infection. Bacterial pneumonia, a ruptured lung abscess, and infection secondary to chest trauma are the most common causes of empyema. And acute empyema means the accumulation of pus in the pleural cavity. The symptoms of lung abscess and acute empyema usually occur 1 to 2 weeks after the causative event, such as aspiration or bacterial pneumonia. The signs and symptoms of both conditions are similar, so I'm going to lump them together because it would be too hard to separate them out. Chills, fever, pleurisy-like pain, malaise, and anorexia. A productive cough develops, which may be purulent, foul-smelling, and blood-streaked. Breath sounds are diminished and crackles may be heard. A very serious complication occurs if an abscess ruptures and drains into the bronchus. A lung abscess may be and often is drained via bronchoscopy, and a chest tube may be used to drain empyema. The rupture of a lung abscess leading to drainage into a bronchus is a frightening, serious, life-threatening condition. I had empyema after my car accident. He was talking about maybe having to put chest tubes in, so the collapsed lung and empyema. But luckily, I didn't have to have that. But since it's such a recent event, it's a good jumping off reference point for these lectures. The next thing we're going to talk about is tuberculosis. This is a huge part of this lecture, so take a little break now, and then we'll come back and start TB. Tuberculosis, known as TB, is a huge public health issue that has a great impact on our society. TB is a chronic, recurrent, infectious disease that affects the lungs as well as other organs. TB is a bacterial infection caused by the Mycobacterium tuberculosis, or M. tuberculosis bacteria, which is a slow-growing, rod-shaped, acid-fast bacillus. Acid fast, because we're going to talk about that later. In the early 1980s, we actually were smug enough to think that TB was eradicated in this country, and TB testing became very slack. Then with the advent of new infectious diseases such as HIV and AIDS, we saw a resurgence of this disease. Because TB, like other lower respiratory tract infections, is an opportunistic infection. Immune-compromised individuals, people living in crowded living conditions, and healthcare workers are particularly vulnerable to TB. TB is one of the leading causes of death, along with pneumonia and end-stage AIDS patients. TB is a highly contagious airborne droplet infection that is transmitted when an infected person talks, sings, laughs, sneezes, or coughs. Many, many years ago, probably when my great aunt was a nurse, they had special TB hospitals. These people were housed in wards with multiple beds. They were instructed not to talk, not to laugh, and not to sing. I'm not sure what they did if somebody sneezed or coughed. So again, TB is a slow-growing, rod-shaped bacteria or bacilli that is acid-fast. The bacteria has a waxy outer capsule, the tubercle, which makes it hard to destroy with normal antibiotics. The infection begins when a susceptible host breathes in a droplet nuclei. The TB bacteria or bacilli can survive outside the host for months in the form of spores, which makes it even more concerning. If exposed to sunlight, heat, and ultraviolet light, the spores will die within hours. Prior to pasteurization, TB was transmitted in milk, but pasteurization, which basically is heat, will kill the spores, and pasteurization also kills strep and salmonella. So with the advent of pasteurization and the discovery of antibiotics, we all felt pretty safe from this disease. And as I said, when AIDS surfaced and changed the complexion of the infectious disease world, this disease came back, and we're very, very concerned about it to this day. Yearly TB testing is now mandatory for all healthcare workers. So this is what happens with TB physiologically. The droplet nuclei carrying the bacillus implants in the alveoli or bronchiole, most often in the upper lobe. And that sets off what you know would be an immune response. And you know this, probably have it drummed into your heads from fundamentals. The white blood cells rush to the area and phagocytes wall off the infection. So that's all good. But because of the waxy outer capsule, the bacilli cannot be destroyed. This walled off area is sealed and is called a tubercle. In a healthy person with a healthy immune system, scar tissue forms around the walled off bacilli and it is further isolated. So that keeps it from spreading. Although the scar remains and can be seen with an X-ray, the person does not have active TB. The patient will be reactive to TB testing by showing a positive PPD, but a positive PPD only shows that you had an exposure or a reaction to the bacteria. It does not mean you have it. Unfortunately, a previously healed tubercle may be activated. This is usually due to a compromised immune system, such as with chemo, with AIDS, with the elderly. When this happens, this is called reactivation TB. So it's not just TB now, it's reactivation TB. About 5% of the people infected with the bacilli develop the active disease, either by primary exposure or reactivation. The signs and symptoms of TB develop gradually. The person will have a low-grade afternoon fever. Then they have other nonspecific symptoms like fatigue. Then they start to lose weight. They notice they're having night sweats. Initially, there is a dry cough, and then later the cough becomes productive purulent and blood tinged. The person is anorexic, and that's basically the early symptoms. TB can invade other organs, however. The signs and symptoms develop in the organ where the bacteria colonizes. The kidneys, the GU system, the central nervous system, and joints are common sites for what's called extrapulmonary tuberculosis. A thing called tuberculosis arthritis may develop in the large weight-bearing joints like the hips and the knees. And then there's something called military TB. They call it military TB because the bacilli march through the body via the bloodstream. A very serious complication of TB occurs when a TB lesion ruptures, allowing the infection to spread to the pleura, which can lead to empyema or pleurisy. So what do we do to take care of tuberculosis? Let's talk about the interdisciplinary and nursing care. Not just of tuberculosis, but all the infectious and inflammatory disorders. But a lot of this, you will see, will be emphasis on TB. First of all is a thorough history and physical, with emphasis focused on respiratory signs and symptoms. Then there's a sputum specimen. A sputum specimen for culture with gram stain is done. If a patient has pneumonia, the organism will be identified, and if the causative agent is bacterial, the appropriate antibiotic can be started. For tuberculosis, and this is important, a series of 3 consecutive early morning specimens are sent for screening for acid-fast bacilli and culture. A CBC, obviously the white blood cell is going to indicate if there's an infection. The white blood cell count is elevated in bacterial pneumonia and probably normal or a little low in atypical pneumonia. ABGs, or arterial blood gases, can diagnose impaired gas exchange. Pulse oximetry below 92 may indicate impaired ventilation or impaired gas exchange. A chest x-ray can differentiate the cause of the infection. The signs and symptoms of bronchitis can mimic pneumonia, so a chest x-ray is done to rule out pneumonia. In fact, a lot of the respiratory conditions have similar symptoms, so you have to be careful with that. With pneumonia, consolidation is going to be visible, as well as the extent of lung tissue affected. What else you can see on a chest x-ray is atelectasis. Atelectasis is a collapsed lung or collapse of a part of a lung. That's visible in a chest x-ray. They saw that in my chest x-rays initially. And then the tubercle of tuberculosis is also visible on x-ray. So you can see the disease. The next thing diagnostically that could be done is a bronchoscopy, where a fiber-optic bronchoscopy may be done to diagnose pneumonia or TB. During the bronchoscopy, a specimen is withdrawn to culture. Sometimes an expectorated sputum specimen is not conclusive because the sputum may not be deep enough when you expectorate into the cup, so they may not get an accurate specimen that reflects what's in the lower respiratory tract. The bronchoscope allows the doctor to obtain a deep specimen. And again, look at that old lecture on diagnostic testing. Then there is what's called a TST, or tuberculosis skin test.
Okay, so now that we've cleansed our hands, you want to take your 0.1 mils of tuberculin solution in your needle, set it aside for now. You need to landmark your location. So for landmarking the location, you want to take the inner aspect of the forearm. You want to go 5 to 10 centimeters below the elbow, and that's the location where you'll inject the solution. So the first step is to cleanse the area that we've now landmarked. Allow that solution to dry for just a moment. And now you want to take your needle, you want to uncap it. With the bevel up, you want to approach the skin at a 5 to 15 degree angle and slowly inject the solution. And slowly inject the solution, and you should see a bleb forming. Once the solution is injected, slowly remove the needle and safely dispose of your sharp.
You probably better know it as a MAN-2 screening for TB. I know you've all had that because you're nursing students, but what happens when you do this test? A small amount, 0.1 milliliter, so imagine how tiny that is, of purified protein derivative, PPD, is injected intradermally. If the person has been exposed to TB, it will activate the purified protein derivative and cause a local inflammatory response. The PPD test is read 48 to 72 hours after the intradermal injection. And intradermal, remember, just goes at 90. I should have brought a syringe. But it just almost is at a 90-degree angle going right perpendicular to the skin. So it just slides right under the skin. A positive result is indicated if the person has a significant induration. Induration is important in deciding whether the test is positive. So an induration is a raised, reddened area. An area of redness without being raised is a negative reaction. If you have red skin where you had your test done, it probably means that you're just sensitive to the PPD. A positive MAN-2 does not mean the individual has active TB. It only shows that they've been exposed to TB. So any induration under 5 mm, so that's a raised area, but smaller than 5 millimeters is negative. An induration of 5 to 9 millimeters is positive for those in close contact with an active TB patient. Those who have a positive X-ray are those that have the HIV infection, a compromised immune system, or an organ transplant. So an induration of 5.9 mm can be positive, but it has conditions. It means that you've been in close contact with an active TB patient. You also have a positive X-ray for TB, or those who are immune compromised or have had an organ transplant. An induration of 10 to 15 millimeters is positive with other risk factors. For example, it's positive if you've recently immigrated from a country with a high incidence of TB, if you're an IV drug user, if you're a resident of a long-term care or correctional system, group home or homeless shelter. And then there's no conditions. If you have an induration of 15 millimeters, that's positive for all of us. However, even with an induration of 15 millimeters, a chest x-ray has to be done to confirm the diagnosis. Some countries, like a lot of the African countries, at one time used the BCG vaccine, the Bacilli Calmette-Guerin vaccine, which was thought at the time to provide immunity to tuberculosis. It is proven that it does not. What the BCG actually did was cause an increased hypersensitivity to the PPD, or the protein that's injected. People who have had this vaccine have a very dramatic result when the MAN2 test is given. The bubble, the little wheel on your arm, just swells to an enormous size, like a little golf ball even. It's over 20 mm's. Anybody who has had this vaccine should never receive the MAN2 test. It's always going to be positive, so a chest x-ray is the only true indicator. Once a chest x-ray comes back negative for any person who has a positive MAN2, they will only need another chest x-ray to rule out tuberculosis if they develop respiratory systems. A chest x-ray confirms an exposure to TB or the actual disease. Remember, the signs and symptoms of TB develop gradually, and they're fatigue, weight loss, low-grade fever in the afternoon, night sweats, etc. At first, the patient has a non-productive cough that eventually progresses to a productive cough with a purulent or blood-tinged sputum. TB will eventually affect other systems besides the respiratory system, like the kidneys, the joints, the GU system, or the central nervous system. If a person is exposed to active TB, they will develop an immune response, which is what you see reflected in a positive MAN2 test, within 3 to 10 weeks. So 3 to 10 weeks after an exposure, the person develops an immune response. And I did mention it earlier, but again, to just include this in our discussion of the MAN2 test, you have to go back and have it read 48 to 72 hours after the initial subcutaneous injection. Next, I want to talk about medications for lower respiratory infections. First of all, there's the pneumonia vaccine. It's recommended for people over 65, immune-compromised individuals, people with chronic cardiac conditions, diabetes, and other chronic diseases. Alcoholics should also have a pneumonia vaccine because they are also more subject to pneumonia. Healthcare workers and residents of long-term health facilities are also offered the pneumonia vaccine. Then there's the influenza vaccine. Usually it's specific to whatever the flu is that year. They usually study the flu. That first starts in the East, and then the CDC and the scientists develop the correct vaccine. And now we can add COVID vaccination to our list. Bronchodilators are given to open the air passages, expectorants, guaifenesin, which, your Robitussin, helps liquefy secretion, so it's easier to cough them up. You don't want to take a cough medicine or a cough suppressant if you have a productive cough. You want to expectorate and get that stuff out of your lungs. Antibiotics are given for bacterial infection. They're first given a broad spectrum antibiotic, and then it's adjusted after the culture and sensitivity comes back. For lung abscess and empyema, IV antibiotics are given for 1 month or more. And now I want to talk about the TB meds. You should know the TB meds because they're a significant part of treating tuberculosis. Antitubercular meds are used to prevent and treat TB. Antitubercular meds are potent antibiotics. They are antibiotics, but they're in a category all of their own that specifically targets the TB bacillus. Antitubercular meds can be given prophylactically or to treat the active disease. Standard medication treatment for active TB is divided into 2 phases. So first, there's the initial phase. During the initial phase, meds are used to kill the rapidly growing bacilli and to prevent drug resistance. The initial phase lasts about 2 months. Treatment needs to begin as soon as possible once TB is diagnosed. During the initial phase, the primary drugs used are isoniazid or INH, rifampin, pyrazinamide, and ethambutol. So these are given for a minimum of 2 months. During the initial phase, the drugs are given daily or 2 to 3 times weekly. The CDC recommends a combination of at least 3 of these primary drugs to help prevent drug resistance. Then, after the initial phase is completed, the drugs are given in what's called the continuing phase. The continuation phase includes only rifampin and isoniazid. The CDC recommends that the regime continue for 6 to 12 months. When the treatment regime is followed for 6 to 9 months, 90% of the affected patients become non-infected within 3 months. The main cause of relapse is non-compliance with the TB antibiotics. So then the last thing here, the last phase would be what's called a retreatment phase. If the medication treatment fails, usually due to non-compliance with the drug regime, secondary anti-TB meds will be used. Retreatment usually involves 4 or more anti-TB drugs, but sometimes 7 or more drugs can be used. Treatment is individualized based on the susceptibility of the microorganisms. Medications with the anti-TB drug continues in the retreatment phase for up to 24 months after sputum cultures are no longer positive. Now I'm going to talk about the specific TB meds. There are primary and secondary TB drugs. The primary drugs are used for the primary cause of TB, which is pulmonary. Remember that TB can affect other body systems. Secondary drugs are used for extrapulmonary TB or other systems that are affected. Or it can also be used for drug-resistant strains of TB. Teach patients to take the full course of these meds. Take a missed dose as soon as possible if it is within a reasonable time frame, and never double up on meds. Because the TB organism is protected by the tubercle, 6 months or more of treatment is necessary to eliminate the bacterial organism causing TB. Teach the importance of keeping doctor's appointments and having regular labs. These TB antibiotics are extremely potent and cause toxic side effects. Almost all anti-TB meds are hepatotoxic, and many are nephrotoxic. So hepatotoxic meaning being toxic to the liver, and nephrotoxic being toxic to the kidneys. Liver function tests, renal function tests, and CBC should be done on a regular basis. The person that is taking these meds should be on birth control while they're taking them, because these antibiotics can cause severe damage to a fetus. All of the primary TB antibiotics are given by mouth. So during this lecture, I'm going to concentrate on the primary TB antibiotics, because the TB organism is protected by a tubercle, 6 months or more, and usually more, I'd emphasize, of treatment is necessary to eliminate the organism. The primary drugs are the first line of defense. Isoniazid or INH. It can be used alone prophylactically to prevent TB in people with TB exposure, and in combination with other drugs to treat active tuberculosis. Prophylactically, that would mean that you were exposed to somebody with active TB and they put you on INH for a period of time to make sure that you don't become active. So prophylactically, INH is given by mouth for 6 months to 2 years. It is used for people who have been in close contact with somebody diagnosed with active TB. Those whose TB skin test has become positive in the last 2 years or show a healed lesion on X-ray, and those with serious illnesses such as cancer or HIV, because they're more at risk of developing the disease. For active TB, INH will be used in combination with 1 or 2 of the other primary meds for 6 to 12 months. More than one primary drug is used to decrease the chances of drug resistance. So you can be on INH, rifampin, ethambutol, or pyrazinamide. So you're going to use more than one of the primary drugs for active TB. So in addition to INH, the person will be on 1 or maybe all 3 of these drugs: rifampin, ethambutol, or pyrazinamide. So those 3 drugs plus INH are given initially to treat active TB exposure or active TB. In addition to INH, 1 or all 3 of these drugs may be used to treat active TB: rifampin, ethambutol, or pyrazinamide. So it could be INH plus 1 of them, or INH plus 2 of them, or INH plus all 3 of them. So the next thing I want to talk about is the criteria for prophylactic use of INH. First would be household members and close associates of a person recently diagnosed with active TB. Second, persons whose TB skin tests have become positive in the last 2 years. Third, persons with positive skin tests and a chest X-ray indicating a non-productive, healed, asymptomatic tubercular lesion. Fourth, a person at high risk of developing TB, for example, someone with Hodgkin's disease, diabetes, leukemia, persons receiving corticosteroid treatment, or other drugs for malignancies. all persons under 35 years of age, and especially children under age 7 who have had a positive skin test. Persons with HIV who have a significant reaction to PBD. Those are the people that are considered appropriate for prophylactic INH use. So what are the nursing considerations of INH? And you should remember these. INH can cause peripheral neuropathy. That means you have numbness and tingling of your extremities. What they usually use to counteract this is pyridoxine, which is vitamin B6. That works very well to counteract the signs and symptoms of neuropathy, which would be numbness, tingling, or a burning sensation in the extremities. Peripheral neuropathy is the most common sign of toxicity with INH. INH can also be hepatotoxic. Drug-induced hepatitis may occur while taking INH. The drug inducing it is the INH. Warn patients to avoid alcohol while on this medication, as alcohol can increase the chances of drug-induced hepatitis. Medications that are metabolized by the liver, such as Tylenol, is contradicted during INH therapy. Severe and sometimes fatal hepatitis has been associated with INH after many months of treatment. When someone is on INH, you need to warn them to avoid foods with tyramine. When someone is on INH, you need to warn them to avoid foods with tyramine. That's aged cheese, aged meats, banana, yeast products, and alcohol. Eating foods that have tyramine in them can cause an exaggerated sympathetic nervous system response, and the person becomes hypertensive with an increased heart rate and palpitations. INH should be taken 1 hour before or 2 hours after a meal. However, like many other meds, it may cause GI distress. If so, it can be taken with food. Remember to teach the person to use birth control while they're on INH, as it is harmful to it can be harmful to the fetus. Rifampin, which is also known as RMP or RIF. This is given in combination with INH and or other TB meds. The nursing considerations for rifampin. It's low in toxicity compared to the other meds in this group. However, when it's given in combination with INH, the chances of drug-induced hepatitis or hepatotoxic reaction increases. Rifampin decreases the effectiveness of digoxin. It increases the risk of hemorrhage if the patient is on anticoagulants. Teach the patient to avoid aspirin and be closely monitored if taking anticoagulants like Coumadin or heparin. Rifampin causes sweat. This is important. It causes sweat, saliva, tears, and urine to turn a reddish orange, which is very troubling if the patient doesn't know to expect that. Explain to patients that this is normal. It is not harmful, but it may permanently stain soft contact lenses. So while you're on a course of rifampin, don't wear your contact lenses. Switch to glasses. Like INH, rifampin decreases the effectiveness of birth control. Teach patients to use supplementary birth control, as rifampin causes serious fetal defects. The third primary drug is the ethambutol, EMB. The nursing considerations for EMB are optic neuritis or toxicity to the optic nerve. It may cause a decrease in visual and color perception, especially when given in larger doses. So optic neuritis is dose-related. This usually reverses when the treatment is stopped, but teach the patient to read the newspaper daily and to report any difficulty seeing the print. Also check color acuity by looking at the same blue object every day and to report any changes. And the person should definitely avoid driving if visual acuity is affected. The person should have regularly scheduled eye exams during treatment. This drug may be safe to take during pregnancy. Again, you'd need a specialist that deals in medication with pregnancy to decide that. EMB may decrease bacterial resistance to other drugs. And in addition to these problems, it is also hepatotoxic and nephrotoxic. The fourth one I want to talk about is PZA, or pyrazinamide. It's also hepatotoxic, so the person should avoid alcohol and other liver toxins while taking it. I think we could safely say that alcohol should be avoided and drugs that go through the liver should be avoided when you're on tuberculosis antibiotics, all of them. The liver function tests need to be closely monitored. It's also nephrotoxic, so that means it's going to raise the uric acid levels. Uric acid, you haven't learned this yet, but when you've got a high uric acid level, that's what causes gout. So the kidney function tests and urine output need to be monitored closely. And of course, because it can lead to gout, although it seldom does, it's contradicted in people that actually do have gout. So those are your primary drugs. The secondary drugs, or the second line of defense, I'm just going to talk about one drug, and that's streptomycin. Streptomycin is a secondary drug used to treat TB. It must be given parentally because it is not absorbed by the GI tract. It is given deep IM. Second-line meds such as streptomycin are given when the TB is extremely drug-resistant. Second-line meds such as streptomycin are often used in conjunction with other primary TB meds for severely resistant TB. Nursing considerations, streptomycin is ototoxic, meaning it affects your ear, and nephrotoxic, affecting your kidney. You've got to monitor closely for signs of ototoxicity, hearing loss, dizziness, or ringing in the ears, known as tinnitus. Having regularly scheduled audiometric testing or hearing testing is a good idea. Streptomycin will be discontinued if hearing loss or tinnitus is reported to prevent permanent loss of hearing. While on streptomycin, the fluid intake should be increased to 2.5 to 3 liters daily, and you should keep a close eye on the urinary output. Check the person's weight at least twice a week and report any weight gain to the doctor. So remember, all anti-TB meds are highly potent and can lead to toxicities. Differentiate which meds are nephrotoxic, hepatotoxic, neurotoxic, optic nerve toxic, and ototoxic. and monitor the patient closely for signs and symptoms of specific adverse reactions, and use birth control while taking TB meds, as they can cause serious birth defects. Have become resistant to the drugs used to treat tuberculosis. Multi-drug resistant tuberculosis, MDR-TB, is resistant to 2 of the primary drugs used to treat TB. That would be INH and RIF, or rifampin. Extremely drug-resistant TB, XDR-TB, is resistant to INH, RF, and many of the alternative meds used to treat TB. So that's very concerning. And hopefully new TB antibiotics will be developed soon. And I want to talk to you about what's called the DOT approach, or the direct observational therapy. Because the anti-TB meds have to be taken for such a long period of time, compliance becomes an issue. Can you imagine? You have to take this medication for 2 years, 3 times a day. It would be easy to slip into non-compliance, especially if you have no symptoms. So to help combat non-compliance, direct observational therapy is used to administer these drugs. This means the patient makes frequent, periodic visits to the doctor or TB clinic, and meds are taken in front of a nurse who teaches and reinforces the importance of taking these meds as ordered. Sometimes a visiting nurse will administer the drugs in person, in the person's home, place of employment, or school. Now, besides medication, there are other treatments and nursing care that are available for lower respiratory infection. So first, of course, you're going to assess your patient, check their vitals frequently, note the rate, depth, and character of respirations, note any changes in O2 sats, check the skin color, and listen to breath sounds. Ineffective breathing and ineffective airway clearance. So you want to assess the breath sounds. You know what to look for. You want to look for crackles, those short, discrete crackling like burning wood. A wheeze. That's that musical sound due to a narrowing airway because of inflammation, congestion, or increased mucus. Wheezing may be heard with bronchitis and with pneumonia, depending on the circumstance. You may hear a friction rub. That's a loud, dry, cracking sound due to inflamed pleura. So the lining of the lungs are like rubbing against each other. That's why they call it a friction rub. And like I said, with a lot of these conditions, especially pneumonia, you get a dull or diminished breath sound. A moist inspiratory crackle will be heard with bronchitis. Wheezing is heard with bronchitis and pneumonia, and dull or diminished breath sounds with pneumonia. You want to position the patient to maximize breathing. So you want them in the Fowler's or orthopneic position. Have the person change positions frequently and ambulate frequently to prevent immobility and help raise secretions. Teach the patient to use slow abdominal breathing. This is going to promote lung expansion. Oxygen can be administered if needed, usually if the SATs fall to 92 or below. So the next thing is to increase fluid to 2,500 to 3,000 to help liquefy secretions unless contradicted. Then the next thing you can do is teach breathing techniques. Slow, deep breathing helps promote lung expansion. Teach the person to cough effectively. So splint your cough with a pillow to help reduce the pain. Encourage the patient to turn, cough, deep breathe, and use incentives, barometry to help clear the airway. And finally, a chest tube may be put in place by the physician to drain empyema or lung abscesses. Next, we have what's called chest physiotherapy. That includes postural drainage, percussion, and vibration. And I'll go through these with you. Chest physiotherapy is ordered when mucus secretions are viscous or thick, or if the cough reflex is weak. So the first thing I'm going to talk about is postural drainage. And the picture I put in your outline might be hard to see, so I'm going to hold this up and I'll also hopefully get a clearer picture for you. But let me hold this up while I'm talking. So postural drainage is going to use gravity to help move the secretions. So you want to have the patient assume the appropriate position to drain the lung field affected. And if you look at the picture where the little dots are, is the lung field affected. The patient is positioned so that the lung area being drained is above the trachea or bronchus. And secondly, the secretions in the affected lung field will drain by gravity. The patient should remain in this desired position for 10 to 15 minutes to allow for adequate drainage of secretions. Postural drainage is done before meals to decrease nausea and vomiting. So if you can, as you can see, the little dot shows the affected lung field, and the corresponding picture underneath that shows you the position the person should be in. Percussion. Percussion is the rhythmic striking or clapping of the back or the chest wall. So you rhythmically strike or clap the back with a cupped hand. You can see my picture of a cupped hand, like that. The patient may be in the sitting or side-lying position. The cupping motion traps air between your palm to help loosen the secretions and move them into the larger airways. You perform another tongue twister. You perform percussion over the affected lung area while the patient is in the desired position. Using cupped hands with your fingers flexed, the thumbs against the index finger. Percuss the affected lung by alternately striking cupped hands rhythmically against the patient. Percuss the area for 1 to 3 minutes. So we're not going to be hitting them hard, but with your cupped hands, you do it rhythmically. Not but over a period of 1 to 3 minutes. Then the next technique you use is known as vibration. Vibrations are produced by tensing and vibrating your arms while keeping firm pressure on the chest wall with your hands. Perform vibration after percussion while the patient remains in the desired postural drainage position. Place surface of one hand over the affected lung field. Place the other hand on top of the first hand at a right angle and provide vibrations for 1 to 3 minutes. Repeat for each lung field involved. The entire treatment, postural drainage, percussion, and vibration, should not exceed 60 minutes because you want to avoid fatiguing the patient. Post-procedure, instruct the patient to sit up and cough and suction secretions in order to clear the airway. So with all of these infectious diseases of the lower tract, there is a risk for infection. Precautions, of course, if the person is contagious. TB patients should be put in a negative flow. TB patients should be put in a negative airflow room that has frequent air exchanges to reduce droplet nuclei and prevent their spread to other areas. Keep the door closed on a precaution room for a client with TB. When you go in, wear a mask, gown, and gloves. And whenever you're caring for the patient, actually, even if you're not in the room, if you're taking them out of the room, wear a mask, gown, and gloves. And especially do this if the person's actively talking. For tuberculosis, wear a high-efficient particulate air filter mask or HEPA mask. You've heard of those a lot lately, to wear them or not to wear them. TB droplets are very tiny microscopic particles that are so much smaller than the droplets of other respiratory infection. Therefore, a filtered respiratory mask is needed. I'm going to restart that. I screwed it up. For TB, wear a HEPA mask, a high-efficiency particulate air filter mask. TB droplets are tiny microscopic particles that are much, much smaller than the droplets of other respiratory infections. Therefore, a filtered respirator mask is needed, or another word for a filtered respirator mask is a HEPA mask. Surgical masks will not protect you from TB particles, which can be as small as 1 micron. The patient is going to wear a HEPA filtered mask when they're transported for diagnostic testing. Teach visitors the importance of wearing this mask. Teach the patient to cough into tissue and then dispose of the tissue in a closed bag. Teach patients that sputum will contain active tuberculosis bacillus for 3 weeks after they start treatment. They should avoid crowds, avoid close personal contact with others, and make sure their living space is well ventilated if they go home. Promote good nutrition. That's going to help with healing. Small, frequent meals help the person to tolerate food better. Try to cater the person's likes and dislikes, foods that are easy to chew, etc. In other words, whatever it takes to get them to eat and promote nutrition. Other things you need to do: monitor the vital signs, temper activity and rest, offer emotional support, reassure the patient the signs and symptoms are going to subside and their activity level will return to normal as the infection runs its course. Refer people to smoking cessation programs, support groups, and counseling if needed. Health promotion is an important part of nursing. You want to promote aseptic hand hygiene, the importance of immunizations, suggest the elderly and immune-compromised avoid crowds, encourage physical activity to increase airway clearance, cover the mouth and nose when sneezing and coughing, so cover your cough. Use disposable tissue to contain secretions and promptly dispose of them when they're used. Explain prophylactic treatment for people exposed to TB and encourage regular TB screening. So until next time, stay safe and healthy and practice good respiratory hygiene. Good night, everybody.